in your headphones.
All right. Well, today we have Dr. Hilda Zorte Gonzalez, newest PhD maybe in the world, definitely in California. So just got her PhD. Have you officially turned it in yet?
Mm-hmm.
Yeah.
Oh, yeah.
Well,
Yeah.
congratulations. Do you want to go ahead and tell us a bit about yourself, about your background?
Sure. Yes. Well, thank you, Dr. Brown, for the introduction. And I'm seeing in the chat a greeting from Mary. I have not seen you in a long time, and I'm so glad that you're part of the best class at UC Merced and the best professor, Dr. Brown. Well, I don't know if I've been a TA for any of you before, but if you do know me, you've known that I've been a pupil of Dr. Brown for 6.5 years. And fortunately, a couple of weeks ago, I defended my PhD and I passed. And it was one of the happiest days of my life. The hardest thing that I have ever done. And like I mentioned to my committee, and they probably all got like, I do not want to know this, but I had 3 homeworks. That is hard. PhD, way another level. Very, very hard. But needless to say that that is something that I really wanted to do in my life. And that's the reason why I came, I want to say came back to the U.S., although when I left, it was not my intention to leave, but I grew up in Mexico, and then I came back 23 years ago. And yeah, luckily, after working for about 14, 15 years in 3 different county health departments and 1 behavioral health department, and also in Indian Health Service funded Native American Health Center here in Fresno, I was able to, well, actually, the stars aligned, and I was able to come to the PhD. But needless to say that I was trained as an economist in Mexico. I got all the way to a couple years of grad school, didn't finish that because I came back to the U.S. to help my grandparents buy the home of their dreams, and my grandparents have been farm workers their entire life. So that is something that I definitely wanted to do. And I stayed because I met my husband, and 3 kids later, here I am. And so what I really wanted to thank Dr. Brown for the invitation. We're going to talk about really an interesting topic that has been around for about a decade, but it really didn't take off in importance in the field of public health as to what the real repercussions are after when COVID-19 happened. And so anything else you want me to mention, Dr. Brown, before I come in?
I don't think so. I mean, you might want to at some point, as you go through this, just kind of talk about health equity within public health departments. But other than that, so take it over to you. So thank you.
That's great. Well, and that's definitely where I want to put all my focus on. And because obviously your course is Introduction to the U.S. Healthcare System, I wanted to prepare today's presentation with that focus. And my experience has definitely been health equity in terms of applying it in Indian Health Service with Native Americans that live outside of the reservations in the urban setting, and which you will be surprised how many in Fresno County, when we were opening the doors of that health center, there were 12,000 Native Americans that were living outside the reservation. And if you're familiar with the Valley, just in Fresno County, we have 3, we don't call them reservations in California, we call them rancherias, 3 rancherias, and a lot more in the neighboring counties. And so I, as a Mexican American, I was very surprised of the sheer, amount of people that were living in different settings than what we previously thought Native Americans were living, or what is the stereotype of where Native Americans are living or how they're living. And so that was definitely my first foot on the door of public health. And then I went to Tulare County, Fresno County, and Madera County, where I had my last job. And so that is sort of the lens that I want to give you. And so, and this is a really a primer in health equity. We're finding out a lot of what health equity means, especially what health equity means in terms of operationalizing it in the different specialties that we have in public health. Dr. Brown, I'm working with Dr. Brown to figure it out how we're going to sort of also assert as a value of our focus, a central theme, equity in health economics. And so first off, I wanted to give you what the learning objectives for today are and what I'm committing to for you to learn today. And we have 5. 1 is to define concepts of health equity and health disparity. 2 is to understand how specific factors contribute to health disparities. 3 is to analyze how the environment and personal health are interrelated. And 4, identify groups that are most affected by health disparities. And we're just gonna, just take a little peek at that. And 5, evaluate how health disparities impact people in California. And as an introduction, this is, there were a lot of perhaps concepts and definitions of health equity. And the one that is the most comprehensive, the one that we can relate to the most and the most eloquent in defining what that is the one that the CDC brought to the public health field. And we understand by the CDC that health equity is achieved when every person has the opportunity to attain their full health potential and is not prevented from achieving this potential because of social position or other socially determined circumstances. And so as it is, this is the most articulate definition that we have, and you see that there's so many layers to talk about what health equity truly is, because it is really not sort of a noun. We are finding out in practice that health equity is something that we really need to practice. Now, in terms of understanding health equity, what we really need to come to terms is that health equity affects the 2 most important things that we should care about in public health. 1 is the length of life. This is how many years we live. And the one that's the closest to our heart as health economists is quality of life, because we have different ways in which we can measure. And unfortunately, in our field of public health, we haven't really addressed how to speak about quality of life in terms of public health programs, public health initiatives, and public health issues. So this is something that we need to be bringing up to the table as health economists. But rates of disease are heavily impacted by health equity, disability, and mortality or death. The severity of disease is also affected by health equity and access to treatment. Now, the most, I guess the easiest way to understand how health equity disproportionately affects groups, we can talk about racial and ethnic minority groups being the most affected by health inequities. And so this is often the framework in which you will see health equity presented to you as a racial and ethnic health disparity, because in the U.S., this is, part of what we speak day to day in terms of our culture, our values, and our politics. And so as public health and health professionals and the system, the language that we use to compare and to contrast and to explain health equity is through measurement. So this is the language in which we're gonna get really specific about health equity, and we can provide accountability, and we can understand it in quantitative terms. And so through many health indicators such as morbidity, mortality, disability, nutrition indicators, quality of life, health delivery indicators, which you've been learning for an entire semester, environmental indicators, which is my work in my dissertation, socioeconomic indicators, social and mental health indicators, and health utilization indicators. This is how, through these measurements, through these indicators, that we can plant ourselves in understanding better what health equity means, and how health equity realizes itself in the different communities where you are going to be working in, and I have been working on, and Dr. Brown has been also working with. So, and what I wanted to show you in that little graph is that this is some types of health indicators, and what you're really seeing at the bottom of that is, the environment, right? The built environment, the city, the suburb, the rural, and the park. And this is very, pretty illustrative of, for example, the Central Valley, and how these places, as they're showing themselves there, this could potentially create health or affect health. Okay, and so a way to think about it and to start reflecting about how these start transpiring, health equity is going to be affecting people is through different questions and answers. And so in our reflection, can anyone think about what are a few reasons why a person might not go to the doctor? And you're probably in your classes with Dr. Brown, you've been talking a lot about this, right? Like the difficulty in the U.S. healthcare system. What are a few reasons why a person might not go to the doctor? And so is there anybody that wants to participate and think about, share with us, what are a few reasons why a person might not go to the doctor in your opinion? I see something in the chat. Let's see. Neftali. Oh, I know a Neftali. Cost, correct, and beliefs. Very good answer. And so cost, beliefs are very important factors, right, in that may affect the decision of a person, or the possibility or the potential to actually go to the doctor. Very good, Natalie. And so for yourself, in terms of your own health, how often do you go outside? Now, we're in this weather that's supposedly, the best weather in the valley. If you know a little bit of air pollution, you don't want to be outside because it's right in this juncture in which we get a lot of problems with air pollution, and a lot of people start getting sick. And so, but you yourself, do you have the freedom to go outside and take a walk, hang out with friends? Is this something that's a possibility for you in your neighborhood or in the dorms where you're at? What do you think about that? And you can do it through chat, or you can just unmute yourself. So even in terms of going outside, having the freedom to go outside and feeling safe in your neighborhood or the place where you live affects your health. So, and if you live in a neighborhood that's not very safe, it's not likely that you're going to feel comfortable to go outside in certain, hours of the day, and you're just going in and out just to conduct, typical business. And so that's one of the aspects of being able to go outside or not able to go outside. And so the other aspects of health equity and starting thinking about that, getting our little gears thinking about that, is how far do you have to travel from your home to find a store that sells affordable fresh vegetables, meat, and fruits? And this is a really huge paradox here in the Valley, because we're talking about, billions of dollars in wealth in the Valley, that are, resting in agriculture. And we don't call it the bread and basket of the United States. We call it the fruit and vegetable bowl, because there's not a lot of wheat here, so we cannot call it the bread. And as it is, we have a lot of people that live in food deserts, right? And also a lot of people that have a lot of food insecurity. So what is this paradox about living in this beautiful valley? If anybody has ever traveled, for example, you go to Japan and you see this one strawberry that's $10, one strawberry. And so eating a strawberry for us, sometimes it goes bad in the refrigerator because it's so accessible for us. And if you can afford it, but this is the reality is that people in other countries, even in other states, and even outside of the valley, do not have access to the bounties that we do. So the other part of it is that yes, we might have, let's say, in our community, grocery stores, but how far are they? Do you always need to take your car, or there's public transportation available? Let me just tell you a little secret. So I said I had arrived from Mexico 23 years ago. I was 130 pounds when I arrived, and I had been a vegetarian for 16 years. So when I came to the U.S., I was like, what am I going to eat now? I don't know how to be a vegetarian in the U.S. So I started just eating pasta and bread, which is, I wasn't going to eat meat. And so within that and the lack of public transportation, because I arrived in a place, I came from Guadalajara, where you can go in a bus anywhere you want. Within 20, 30 minutes, you'll be there, and the buses are always, showing up. No problem with public transportation. When my grandparents wanted to go to their English school, right, adult English school, it took us an hour, 15 minutes to go from their side of town to downtown Fresno, which is only in the car, it really takes us 7 minutes to get there. But in public transportation, you have to take two connections, and you had to wait, 30 to 45 minutes for that bus. So I couldn't believe it. I just couldn't believe it. And so that is a huge issue in the environment in which, we may have grocery stores available, but how do we get there, right? And transportation is definitely something to think about when it comes to health equity. And so this is really how we can better comprehend what equity is. And we talk, in our country, it has wonderful values. And I am very proud of being an American. And so we talked about all of us being equal. But in public health and in healthcare, right, we need to go beyond that sameness. And as you see in the top of that picture, we say, okay, well, let's say you're all public health directors and you decide that everybody needs to, start using active transportation, which is either walking or cycling to anywhere you want. And so guess what? I got a big grant and I'm going to give everybody a bike. So, genius, right? You're all genius public health directors because you're going to get everybody active. And yes, they're going to get healthier. There's going to be less cars around, a lot of benefits from cycling. But if you got a grant to give everybody the same bike, what is the problem? Okay, it's laudable, it's great, okay, it's a great initiative. But is that same intervention, the same intervention is going to benefit everybody the same, equally? And so are we being equitable? And the answer is, there's many cases in which one size does not meet everybody's needs. And so that in terms of equality, it was great. We gave everybody a bike, we made it. But that was not an appropriate bike for a child. It was the perfect bike probably for that young woman, not so much for a person as tall as Dr. Brown, because he will be, in his bike doing this. and obviously not good enough for a person with different abilities. And so if we actually think about equity, we always want, yes, to make sure that everybody has the same right to active transportation in this case, right? It's just an example. And we're going to give the child the adequate bike. The young woman has the perfect bike. The tall person also, you know, tall young man also, and the person with different abilities, the right bike with the correct adaptive technology that she needs to get around town. And so what health equity means is that each person gets what they need to achieve optimal health, right? And some people need more than others to reach the same level of health. And that's just, you know, a matter of fact. And so disparities are differences in health outcomes that may arise due to health inequity. And so if I am just this, you know, super bright, we're all super, you know, the gung-ho public health directors that gave everybody a bike, we are going to, despite being this a genius intervention, we're just going to create health outcomes that are not the same for everybody because we originated a health inequity. And so how about that? This is a really difficult thing to grasp, really. And so what very, very soon health equity started to sort of realize itself in is that not only we needed to think about it theoretically, right, as to what we need to accomplish, how we need to think, how we need to adapt our interventions in public health and in the healthcare system, but that we wanted to do more than just have a nice theory about how to, you know, give people the necessary or meet their needs in an appropriate way. And so what public health departments and what public health scientists and public health institutions start to think about is that in practice, health equity needed to have 3 aims. And this is very a common sort of pragmatic way of creating deliverables for initiatives. And so to give them aims, right? And so in this case, health equity started evolving into these triple aims in which we all needed to thrive as the public health system, as the U.S. healthcare system. We needed to thrive to implement all health in all policies approach. So, and with the goal to be health equity. And so this is when when we started hearing that public health departments started getting involved with deciding how the general plans of the cities or the general plans of your towns, and to get involved in how we were going to influence decision making in the city level, at the county level, and at the state level, in how health is created or how health is not created by the various policies of whatever jurisdiction that you live in. And so the other part is to expand our understanding of what creates health. And this is really the piece that I'm going to talk a little bit more about in a few slides, because yeah, what does create health, right? And so we may be understanding of what creates health for us, but when it comes to understanding other groups and understanding our neighborhood level and our city level, how do we do that? And so, and then the one that we see a lot is to strengthen the capacity of communities to create their own healthy future. And this is to start bringing to the table people who are typically not invited to the decision-making processes in any city, any town, any place. And so you saw a lot of hospitals having advisory committees in which they had their own patients to be part of, having it. You saw a lot of expansion of, for example, in the Affordable Care Act, you saw specific determination in their needs assessment, in which the needs assessment needed to have a really strong, I guess the way to say it, inclusiveness of the community that where the nonprofit hospitals were at, so that they could keep their nonprofit status. And those reports and that form a relationship of the hospital, right? The big hospital and the big hospital honchos. They were actually talking to the community, and they were forming advisory committees with their patients and people in whatever towns they were, and they were telling them, this is not working in your hospital, or this is working great, and this is what my community is talking about. And so you saw that many of those things in terms of health equity started infiltrating sort of the way that we started doing business, or that we usually did business in public health or in the healthcare system. So those became sort of like the really granular things to do when it came to day-to-day things that we did in public health. And so whenever you went to a new conference to start promoting health equity, there's always a fable. And this fable is, it's just a way of using art and sort of folklore into understanding concepts and what we want to do with those concepts. So today there's many videos about health equity and what we really are doing through health equity. But I thought this was one sort of like the nicest ones, and because we're in the Central Valley, it kind of looks, like the mountains and the man-made rivers, and also the San Joaquin River, which is natural. So let's look at this video, and it's very short. It's only 2 minutes.
Hilda, we can't hear anything.
Oh, you can hear it? Oh,
no,
okay.
We can't. I think you have to go down on your and
on the okay. They share the sound.
Share the sound, yeah.
Then sharing. Okay. Sorry. It's not here. Let's see.
I can make you host. Let me make you the host too.
Oh, okay. So
yeah, so you should be able to go and under
here. I think I got it.
Yeah.
I got it. And share. Yeah. A little bit.
In a small fishing village.
Is that good?
Yeah, except we can't. You have to share the screen again.
Not long after they got there, a child came floating down the rapids calling for help.
Well, you have to share the screen.
One of the group on the...
Oh, I thought...
I think you went before share. Yeah.
Okay. Sorry about that. So it's kind of restarting the share.
Yeah.
Share sound. Okay. Okie dokie. Let's try again. Okay.
In a small fishing village, a group of folk gathered at the river. Not long after they got there, a child came floating down the rapids calling for help. One of the group on the shore quickly dived in and pulled the child out. But minutes later, another child came in, and another, and then many more children were coming down the river. Soon, everyone was diving in and dragging children to the shore, then jumping back in to save as many as they could. In the midst of all this frenzy, one of the group was seen walking away. Her colleagues were furious. How could she leave when there were so many children to save? Then, after long hours, to everyone's relief, the flow of children stopped, and the group could finally catch their breath. At that moment, their colleague came back. They turned on her and angrily shouted, "Hey, how could you walk off when we needed everyone here to save the children?" She replied, "It occurred to me that someone ought to go upstream and find out why so many kids were falling into the river. What I found is that the old wooden bridge had several planks missing, and when some children tried to jump over the gap, they couldn't make it and fell through into the river. So I got someone to fix the bridge.
Right. So this is a very typical video that you will see in introducing what health equity is really wanting to do. And in the field, we started calling it going upstream, because what we were doing typically in the public health system and in the healthcare system is dealing with the problems and the health outcomes of things that we didn't know were happening. And so this is the new task for public health, was to start looking at the root causes of all the issues that we were seeing in public health, or the root causes of all the adverse health outcomes that we were seeing in the system. And so, again, very using art and using, visual, right, pieces to start understanding what we wanted to do in public health and in healthcare. We started talking about upstream, downstream, and everything in between. And so what this means is that in one way, the entire public health system and the healthcare system was too focused on the individual impact of things that we didn't know what they were. Okay, so this is where we're starting. So this is the sort of the historical aspects of how we came about with health equity and how it came to us. I wasn't there. And so in the way that we were taking care of these impacts, these health outcomes, is by providing direct medical care, right? Clinical care services, medical interventions. We gotta heal people, okay? And then patterns started showing up, and thanks to epidemiology, right? And thanks to population health, we started seeing that there were some things, and a lot of research, right? A lot of research. We were starting to see things that there were things that were modifiable, and at other levels, like in this case, the neighborhood impact. If we started addressing individual social needs, we could potentially have an impact in those health outcomes. Yeah. And remember, when we talk about measures, and this is in terms of lingo, this is when you hear, oh, we're going to move the needle. What needle? Okay. The needle of health measures, right? The needle of health outcomes. Ultimately, yes, we want to see impacts in health outcomes. But before we see that and we start addressing, going upstream and figuring out the root causes of the problems, how they were showing up in terms of medical and clinical care services, how can we address this? How can we influence the mitigation of all these factors so that we didn't continue to see so many adverse health outcomes? We're talking about diabetes, we're talking about high blood pressure, we're talking about chronic diseases, and very impacted by chronic diseases in that epidemiological transition, right? And so it's, again, a new way of seeing things. But then we actually, these in neighborhood impact, there's another level, which is the one that people are really talking about upstream. Sometimes people get really wild in what they really describe as upstream, but the practicality of those things is wonderful to think about it. It's wonderful to think that we could do a lot about changing an entire system. And what in public health and in healthcare, we really need to have a community impact, improve the community conditions, and that change in policy and environment. That is where we really can go in and start making suggestions as to what other, let's say, county health departments and other county departments that were part of the same jurisdiction could do to impact health. And guess what? That started resonating significantly with other departments and also with the healthcare system. So I just want to make sure that we become familiar with these terms of upstream, midstream, and downstream, you're always going to hear more about upstream, okay? Because this is a new way of seeing that health outcomes. In this case, you saw it in that little video, as children, right, drowning, and the community having one by one, having to rescue these kids. But at some point in time, you know, everybody was tired, they accomplished the task. But what was the underlying issue? That someone finally went upstream and saw that the bridge was broken. And then the idea was that upstream, she asked somebody to fix the bridge, and voila, the whole problem was solved. Sometimes you're going to find problems in public health and healthcare that are really that easy to solve. You would be surprised. In reality, we have a lot more issues that are a lot more complex, and thus we need to start talking about things that are a little bit more intricate. And the main thing is the understanding of them. So just remember, upstream, downstream, and everything in between, that's the midstream. This is what the impacts in health are. And so those things that I was kind of, you know, wanting not to mention until now are social determinants of health. And this is something that you probably heard, you know, being in upper division so much, right? Social determinants of health. But how are social determinants of health related to health equity? And so let's start by remembering what social determinants of health are. So these are factors, right? These are factors that are social, economic, and environmental conditions that basically impact a person's life, right? And that impact is described in their health, right? This is the impact we're talking about, is the impact in their health. And so in terms of, let's say, healthcare access, which is something that you're studying right now, Dr. Brown, and the quality of that access, okay? And so how does healthcare access and quality affect our health? And then education access and quality. So by now you are all experts in the fact that education, is one of the #1 predictors of your health later on, correct? So the people who are the healthiest in our nation, right, and in other nations as well, because we can actually compare and contrast not just within countries, but also between countries. And in this course, you learned a lot about that. And so people who are like you, right, who are going to be college graduates are the most likely to have the highest sort of quality of life, right? And so being educated gives you access and quality of health. And so also the social and community context in which you live will affect your health. The economic stability. And we saw these, right, in COVID-19, because what we were trying to make sure that during a pandemic, no one fell through the cracks in terms of needing the basic things. And so we decided, you know, as a society, that we were going to help people, right? Most people, not everybody, because some immigrants without documents that were working were asked out. That, you know, people were going to have access to funds, right? The famous tax incentives, or I remember the pandemic, I don't remember them, but we all started receiving some funds, right, to stay home and to survive through the pandemic. And then we declare a group of workers to be essential workers because we needed, you know, we needed to keep our basic economic structure in place so that we can continue to be a functioning society. So your economic stability, including the level of poverty that you grew up with, okay, and the economic stand that you will have in your cases, for example, after you graduate from college, is much different, okay? And so that will affect your health and any person's health. And of course, the old adage that where you live, right, the built environment is one of the most important determinants of your health. And so addressing these factors can help improve overall health. Now, whether or not in the long term we will realize in health outcomes, there's got to be, right, some intermediate evaluation of it. But it's true. I mean, it is true that if we lift people into better conditions, obviously we improve neighborhoods and the built environment. We make sure that everybody, the U.S. becomes a much more equal society. Have you heard about income inequality? So that is a pretty big issue for economists, and it's a pretty big issue for public health. And so that our community context, our education access, and healthcare access is improved, we should be seeing an impact in health outcomes. And that's the downstream, right? So we go upstream through looking at the root causes of what could potentially be impacting person's health, and that's basically where we're looking at that. This is upstream. This is working upstream, okay? Not just in providing medical care and clinical care, which is very important, but what else can we do so that we can improve factors that are modifiable? And so let's think about it for a little bit. And so here I give you a little graph in which the Kaiser Family Foundation describes what social determinants of health could be, right? And for example, you have those 6 arenas in which economic stability, again, neighborhood, physical environment, education, food, community and social context, and healthcare system. Those are the things that we see that are, the potential indicators for it. So in economic stability, a person that has employment and income, right? How, their expenses that they have, the type of debt that they have. Have you ever heard, for example, of banks not being available in poor neighborhoods? In poor neighborhoods, what they have the most are those, paycheck stores in which they loan you money. Basically, they're shark loans, right? They lend you money for, I think the rate is like 70%. So it's outrageous. And so, but people need access to funds, medical bills, and we're sadly not very famous for our medical debt and the support that, or safety net. This is the safety net, the economic stability. For example, when you lose your job, what kind of unemployment is going to be available to you in your where you live, right? In this case, our state does have some of those benefits. In your neighborhood or your physical environment, we're talking about the type of housing that you live. In other classes, perhaps, even in this class, we've talked a lot about having an issue with lead in paint, right? So as a country, we had to come to terms with the fact that lead in paints was not good, and it was creating a lot of adverse health outcomes in children and in people, right, and adults too. And so we decided to gradually get rid of lead in paint, and a lot of houses started being treated for lead paint and lead paint removal. And so the quality of housing is really important. Transportation that we have, safety is super important. Parks, what green space we have available, playgrounds, walkability, and this was very important in a point in which we look at zip codes in terms of figuring out what the health of people by zip code were. In education, your literacy, we talked about what could potentially happen when you finally achieve that bachelor's degree, right? Language, early childhood education, vocational training, and higher education, and food. A lot of food insecurity in the Valley, and hunger is a significant factor in your health, and everybody's health, access to healthy options for food. And in the community social context, again, social integration, support systems, community engagement, discrimination, and stress. Whether stress is, your normal stress, or if it's toxic stress that you're being exposed to. And what you're in this course to understand is the healthcare system, right? The health coverage, which is the main door that we all have to cross to obtain any healthcare in the U.S. Well, any typical care, and provider availability. And you know that you live in a medically underserved area with very few providers compared to other parts. Now, whether or not the provider is competent, linguistically and culturally to help you deal with your health and the quality of this care. So all of these things work together to create health outcomes. And so we talked early on about those measures: mortality, morbidity, life expectancy, health expenditures, health status, and functional limitations. And so this is the way in which we can think about how does education, access, and quality connect with other categories of social determinants, right? And so at this point, I'm going to ask you the same question again. In sort of being exposed to these, all these lingo and all these terms, now, can anybody tell me a few reasons why someone might not be, might be unable to get medical care? So let's start using a little bit of, the language of health equity, those terms. So now with things that we're learning, what are 4 reasons, in which someone might be unable to get medical care? And using these social determinants of health. Where is the chat? My chat is being up here. Okay. So I know Neftali used to be very participative in the chat. Are you going to continue participating, Neftali? Anybody else that wants to chime in? So at this point, right, of the lecture, this presentation, this talk, tell me a few reasons why a person may be not able to get medical care. What social determinants of health could be in the way of obtaining medical care? Anybody? Should I call people, Dr. Brown?
Sounds like a test question to me. So
just use
give them
the
multiple
social determinants
choice.
of health.
Give them multiple choice.
Okay, sounds great. So let's say, would having a playground in your community be an obstacle for you to get medical care? Your neighborhood and physical environment, in this case, a playground specifically. Yes or no?
Are you talking to me? What's the question?
Ask the
All
question
right.
one more time.
Okay, I'm going to ask the question one more time, and it is a yes or no question. So using the social determinants of health, can you explain if playgrounds, right? Can you say yes or no? Playgrounds could be an obstacle for people to get medical care.
A playground?
Mm-hmm.
I don't really think it is that linked to medical care.
Yeah. Okay, great. Perfect. Even though that's a component, right, of your neighborhood, that may not be. But what about transportation? Okay, so Lisbeth says yes. So transportation, Daniela too. Okay, very good. Now, let me make it a little bit harder. In the terms of community and social context, would discrimination be an obstacle to get medical care? Okay. Oh, lots of yeses. Look at that. Yeah. All right. Can somebody explain why? Right? Why would, and some for sure. Why would discrimination be an obstacle? Yeah, to obtaining medical care. And you don't have to get like super philosophical, but just a sentence of why, if you feel discriminated against, you wouldn't, you wouldn't seek medical care, or a person is unable to get medical care. Just a really simple way. I mean, I know, this is charged, and why? I mean, we're very empathetic human beings, but why would discrimination be an obstacle to medical care? Again, we're public health, right? We're healthcare providers. Okay, so Ashlyn says it affects the trust, excellent, in the medical system. A key word, Ashlyn, very good, trust. And Neftali, because the doctor might limit the options to the patient just because he doesn't want to go through that with them because of the way they look or how much they can afford. Excellent. Okay, so those are two excellent questions. And that is true. As public health, as healthcare system, why will we be worried about discrimination? Okay, so that is not something that we typically saw, right, to be part of the arena of public health. Needless to say that since the advent of health equity, we have had to look upstream as to how it is actually affecting health outcomes. So there you go, you guys got it. And so this is the way in which we start analyzing and reflect about health equity. And then Kel says, I believe everyone should have access. There you go. If they can afford it, health is very important regardless of what race. Excellent, beautiful. And so this is great reflection. And yes, this is the way to start thinking about how you look at equity and health equity in our specific way of using it in public health and healthcare. This is how pragmatically you can look at social determinants of health being what's upstream and affecting the health outcomes of people, right, that are entering the system for adverse health outcomes. Very good. And so generational poverty occurs when 2 or more generations of a family live in poverty. Why do you think the cycle of poverty is so hard for families to break? Now, again, this is a question about social determinants of health, right, that we don't typically see as being the realm of health, healthcare, and public health. Needless to say that the cycle of poverty or poverty status is an important, very important determinant of health. So is anybody a scholar on poverty in this group? Does anybody have strong, ideas about, or any ideas about how cycle of poverty for some families is so difficult to break and how that might impact I mentioned to you that I work in Indian Health Service, right? And so that was a very good way for me to understand how many families can't break the cycle of poverty. And we're talking about that most people think that Native Americans have access to casino money. That couldn't be further from the truth. And that is one thing that we definitely, as public health professionals and health professionals, whatever you want to be in your life, that's how you think about it. That's how you think about the system. That perhaps we are functioning, right, with ideas about, certain groups, but in reality, how their daily lives are really, exercising may be completely different to what we previously thought. And we need to understand that. And we need to understand that because our job, right, our job is to make people's health better. Okay. And so, very good. Thank you for those answers you gave. And so, yeah, I will be remiss not to talk about COVID-19 because, like we all saw, that health equity really became central to the whole COVID-19. You couldn't watch the news without hearing about health equity. And so let's watch this little video that it's a little bit self-aggrandizing, but it's the CDC, so we gotta give them a little break. Let's see.
Early on in the pandemic, we started to observe the disproportionate burden of COVID-19 in communities of color. When you move into a community and you're looking at, okay, where do we need to put the resources, and making that connection to COVID-19, where we were seeing some of the same issues play out, people that were low income, people that had working multiple jobs because wherever they worked, the pay was inadequate, so they needed to have supplemental income. For us, it was really important to make sure we were gathering the data on race and ethnicity as soon as possible. Health inequities include things like not having health insurance, not having paid sick leave, where people live, where they learn, where they work, where they play, even where they worship, impact health outcomes.
TIFA and CDC are committed to building community resiliency through a variety of social determinants of health.
The Chief Health Equity Officer Unit, or CHEO as we refer to it, was established so that there would be an entity that had the sole focus of ensuring an all-of-response approach to addressing COVID-19 disparities.
We're all on the same team. We also have to make sure that people understand when we say racism is a public health crisis, it's meant for us to bring about change. When we look at the pandemic and all of the loss that's been associated, there has been some gains that we also have to acknowledge. Gains helping us to recenter what matters most within our own lives, but also as a society, as a country.
The opportunity to present to President Biden and Vice President Harris the work that we have been doing, it was beyond inspiring.
You all are a model for the world around what can be done.
There's a movement, an awakening in this country that people are paying attention, that there's inequities. We have to do better. We have to make sure that policies are developed from an equity perspective, that community is involved in the decision-making process.
Recently, CDC launched its first Racism in Health website, which will be a central site where we will capture the work that's going on across the agency. We will see the end to the COVID-19 pandemic, but that's not a time for us to back up and turn away from the investments and the energy and the commitments that we've achieved in response to this pandemic.
We can't go through this again. We have to be strategic. We have to be willing to invest in public health.
This is the time when we can continue to build the infrastructure of our public health systems. This is the time when we can continue to partner with multiple sectors in our society. This is the time when we can join hands with community members to continue to press for greater health promotion, greater health equity, and the end to health inequities.
I love this video. I mean, in the CC Beat Club, the most handsome people they had in the video, but I really love it. And so, just because time, we're getting really close to 4:15. I just wanted to press to you, for example, again, another thing that we don't typically talk about public health is that people in wheelchairs, right? They also have a right to receive the highest quality of care possible. But what happens when you are in a wheelchair, you're a person in a wheelchair, and the built environment, your neighborhood, or the place where you need to go get care does not have what you need to be active in your wheelchair, to get there in your wheelchair. That is a significant issue, right? That it impacts a person's ability to access healthcare. And what happens is that I need you to think about a little bit more about property taxes in this case, because property taxes, are how we pay as a society for those improvements and amenities in the built environment. Now, when you have a limited outcome and limited income, right? And you live in poverty and you live in a neighborhood where perhaps properties do not have the highest values to actually charge more for taxes. Now, what happens to poorer communities, right? Those communities where their real estate is not as valuable as those communities with the higher home values. And what happens to the built environment? Do we have differences in those neighborhoods about what sidewalks look like, what the access for people with different ways of access transportation is? So this is something that, in a way of framing health equity, and this is a health inequity, right? That in terms of us financing better built environment to stimulate, right, or to influence health, we have significant issues on how we finance that, and that is a health inequity. And again, just becoming familiar with what the terms in health equity are. And so these are terms to know. Maybe Dr. Brown will include this, in your test. And so these are terms to know, and very important in terms of this entire framework. So we're going to talk about disparity, right? Disparity, as we mentioned, these are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health. And health inequity are when factors like education, income, gender, environment, and ethnicity cause unfair differences in health outcomes. And the built environment is the human-made environment where people live, work, and play each day. Health equity is when everyone has the opportunity to be as healthy as possible. This is definitely a goal, right? Public health is the science of protecting and improving the health of people in their communities, which includes our healthcare system. And social determinants of health, like the foundation of it, are the conditions in which people live, work, learn, and play, and these can contribute to health inequities, okay? So these are the terms of this entire framework. This is something to become familiar as you progress in your professional careers in the field. Now, Dr. Brown, should I go just go through the slides of the, comparing different groups?
We know we've gone through
Just
this to some
faster.
degree. So I think we probably, so if you want to go, how many more slides do you have?
Like 10 more. Yeah, but they're all indicators, just, to compare.
Why don't you go through them quickly? Because we've seen a lot of this before, so why don't you go ahead and.
Yeah. And I do remember teaching your class, so that's why I think that your students are incredibly familiar with this. But yeah, this is a way to start looking at what health equity is in terms of the health outcomes, right? How you're measuring and moving the needle. And in California, we can talk about health equity in terms of race and ethnicity. This is what you will look at when you're looking at health disparities by race and ethnicity in California. Now, what we need to look at to begin with is who lives in California. And here is giving us a taste of, in 2010, who lived, in 2020, how we are more alike. But what we're expecting in California to be and look like in 2040 is that California is going to be 42% Latino, Latina, and Latinx, and 36% white. No, not a lot of changes in the other groups. Okay, so think about that for the future. And in life expectancy, again, comparing it in terms of measures and health outcomes, life expectancy by race and ethnicity for Californians, for the whole state is 81. Asians seem to be having a higher life expectancy, and Latinos and Latinx, American Indians and Alaska Natives, whites 79, and Black people, African Americans, having the lowest life expectancy. You've seen this, in your class, health insurance by race and ethnicity. This is who have employment based and who have privately purchased, but who is uninsured and who relies on the public system, which is largely Latinos. Who is delaying the most care due to cost and lack of insurance by race and ethnicity are Latinos, okay? Almost, 38%. And so another important health measure are asthma emergency department visits for children and adolescents. This could be an indicator of not having our usual source of care or to be exposed to environmental factors. And we have the highest for Black children and adolescents and for Latinos. Now, teens who are overweight and obese by race and ethnicity, we gotta get ready for this. Latinos are 15% and 25.6% obese. Now, with opportunities to be physically active, we talked about the built environment, the safety, having parks, right? Green spaces to do it. Black people are the ones that have reported the least amount of adult physical activity. Now, this is the other side, suicide rates by race and ethnicity. The majority of people who are committing suicide are white, and in an important health disparity here to pay attention to, okay? What is happening going upstream, think about it, what is happening for this group that they have this significant health disparity. Now, another way of seeing health equity, and you can see it from many different points of view, but one that is really close to the work that we do in Dr. Brown's lab is to look at rurality, right? Rural equity. And so here, and you'll probably have these slides available to you, you can see and compare the different by level of urbanization. We call it by rurality because, you know, we want to give people in rural areas, you know, there's nothing wrong with living in a rural area. The problem is what's available in rural areas or not available that is contributing to health disparities. And in this case, for people who are uninsured, here in the rural areas, which is this blue dot, is much worse, right? The clinical care is much worse for people that are uninsured and living in rural areas. But who is uninsured and lives in large suburban areas, they have the best care. Now, for the rural people, people who live in rural areas seem to be having worse outcomes in terms of preventable hospital stays. And so in health behaviors also, rural communities overrepresented in the worst health outcomes in terms of behavior, smoking, obesity, and teen birth. I don't know if you know this, but Madero County and Kings County and Tulare County have the highest teen birth rate in the entire state and some of the nation. Now, we were going to do an exercise. Do we skip it, Dr. Brown?
Mm-hmm. Probably so. I think we have run out of time.
Mm-hmm. And so we were going to show you this beautiful website in which you can actually go and explore in terms of comparing and contrasting what the health ranking of that community, and it could be a county, it could be a city, or it could be a zip code. And you can actually look at the different indicators that contribute to health. And again, the health outcomes, what we care for is length of life or life expectancy and quality of life. Okay. And what is contributing to either having better quality of life or worse quality of life, or living longer, or, you know, having an impact in our life expectancy, are all of these factors that you can measure, right? All of these indicators and all of these opportunities for policy and environmental change. And so that activity, where we're going to bring you back to pick one of you or several of you and to tell us, right, what in that neighborhood or town makes it healthy or attractive or desirable to live there, and what's in decline, unattractive, and undesirable. And this is how you start identifying what things can potentially be enabling health and what things are impacting people's health. And those are the things to start influencing in terms of promoting health equity and hopefully reducing health disparities. And so what I wanted to conclude is, well, you're in the course of the introduction to the healthcare system. Does the healthcare system care anything about health equity? In the last survey that they did, they do it every 2 years, health equity ranks number 2 concern for the entire healthcare system. We're talking about a survey that's done by with hospitals, clinics, clinical systems, etc. But the Institute for Healthcare Improvement is surveying all of these entities, and they said number 1, safety, number 2, health equity, and number 3, health. Okay, but health equity is at the forefront of what we need to become familiar and start identifying and using, those terms, and starting reflecting and analyzing public health and healthcare and health outcomes in terms of what do we need to do, right? Okay, and that's us, right? That's our beautiful school. We love it. Yeah, we love walking around it. Hey, any questions?
All right. Well, thank you, Hilda. That was great. I really appreciate it.
Well,
Everyone will meet on Tuesday for a review session, and I'll make the slides available online. So thank you, Hilda.
Yeah, and you're all done. Congratulations on this semester, everybody.
Yeah. Are we going over the assignment? Do you want to go through the assignment? I mean, do you have questions about the assignment? Okay, what's your questions about the assignment? Well, I'll pull the assignment up. You can take off, Hilda.
Okay. Bye,
for those
everybody. Nice seeing you.
Oh, can you make me host?
Oh, I'm sorry. Yes.
Yeah, that's right. I made you host, so.
That's true. That's true. You're back. Yes?
Yeah.
Okay.
Yep. Good.
Dr. Brown, complete.
I mean, in terms of how to do the assignment, well, watch that. If you look at the videos of, go through the lecture notes on how we did the, for pharmaceutical, is that I kind of go through an example of how to do it with different numbers. So, you probably have to ask me a more specific question than that. Yeah, so go through, you have it till, I'll accept them up until midnight tonight. Sound good? Okay, bye-bye.